be brave if you're brave. I'll be brave, but only if you're brave. Yeah, we can both be heroes, like soldiers in their nice clothes. Like soldiers in their nice clothes, together. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this, like sailors in a tempest. Like sailors in a tempest, together. And it could be just you and me. We'll be family. Just wait and see. So I'll be brave if you're brave. I'll be brave, but only if you're brave.
All right. Welcome, everybody. Good evening. Thank you for joining the Lung Cancer Living Room, hosted by the Go-To Foundation for Lung Cancer. We're so excited to have so many of you here with us tonight. As you can see, we've got a full crowd, and we're very, very excited about that. For those of you who weren't aware, I am not Danielle. She is much older than me. It's true, she just celebrated her birthday, and so she's older than me again, briefly for a period of time. And certainly Bonnie is not with us either. They're actually in Ireland as a family for a wedding, and so we do miss them, but I have a sneaking suspicion. We were talking earlier, Bonnie tends to be an early morning person, and I would not be surprised if she's actually online watching. So Bonnie, welcome.
Hi,
We're glad to have you watching, and thank you for what you've started here, because look at this amazing, amazing crowd. So I'm very excited. As usual, we'll get started with an around the room here in just a moment, but we'll do a really quick introduction. We'll save a deeper introduction for you later. But joining us tonight, as many of you had seen, Professor Heather Wakelee from Stanford University and Dr. Amy Moore from the Go-To Foundation. Absolutely clap. And again, I'm David LeDuc. I'm the Chief Growth Officer for the Go-To Foundation for Lung Cancer. I've been with the organization for about 4 years now and in the lung cancer space for about 10. And I'll share a little bit more about my story and how it relates to our topic for tonight around how lung cancer is really shaping the treatment paradigm for a lot of other cancers. Just an early thank you to all the people on staff who've gotten everything set up for tonight. Thank you, all of you, for coming out. Thank you for my second or third glass of sparkling wine here. It was a late start, okay? So I might have had an extra glass to get us going, but we are excited. So as usual, if it's okay, what we'll do is we're going to get started with the Around the Room. A shout out to the people online. Dr. Jennifer King is hosting our Facebook feed. I think Kim Parham is on the YouTube one as usual. For people who are online, welcome. Thank you for joining us, and feel free to ask questions. We'll do our absolute best to get them in, but we can't always guarantee we're going to get to every single question. Just know that we do take those questions and try to respond at a later point if we're able to. And then normally it's Amy and I kind of hosting things on the Facebook. So we're sorry we're not on there with you. We miss you, and we'll be back next month online with all of you. So thank you. So who wants to get us started with the Around the Room? Don't all speak up at once, or I'm going to call on somebody.
And we do have some more seats up front.
Yeah.
Anybody standing and would like to
Yeah, come on in, please.
So.
But yeah, if you want to get us started, that'd be great, and we'll get it going.
Okay.
Yeah.
My name is Tina, and I came here about 7 years ago, and Bonnie was or 8 years ago, I think. And Bonnie was my inspiration. I was, right finished with chemo and radiation, and I looked at her, and she was 6 years at that time. out, and now she's 14. Yikes. Anyway, she gave me so much hope, and now I think I can give it to a lot of other people too. I just had
Absolutely.
a PET scan and a brain MRI last week, and they can't find anything. So, and that's been 8.5 years. So I'm on my way to meet up with Don, who's celebrating his 10th cancerversary this weekend.
Okay, so I am Barb representing my husband Dave, who's not here tonight, but I'll try to give the fast version so you can all figure out how where your touch points are with Dave. He was diagnosed in March of 2017 after having unresolved mid-back pain with stage 4 non-small cell adenocarcinoma. He had mets to the brain, lymph node, and extensive pleural effusion, which is fluid in the lining around the lungs. And that testing of that tissue in that fluid led to the diagnosis that his cancer had the EGFR mutation. So first thing they did was stereotactic radiosurgery, radiation to the brain to deal with the lesions in his brain. There were 6 of them. And then he they drained the pleural effusion in his lungs, and then they started him on Tarceva. And life was pretty good for about 20 months. And then things started to spread, first to the bones where he was having a lot of pain. So they put him on Tagrisso. Even though he was not T790 positive, which some of you know what that means, but usually a requirement for the Tagrisso. But because he'd had a serious rash continuing to get worse, he was eligible to be put on Tagrisso. So his next scan showed that it had, in fact, continued to grow. Pleural effusion was back. It went into his liver, more lymph nodes, and more bones. So they took him off the Tagrisso, and as of January of this year, they started him on carboplatin and Alimta chemotherapy, and went through 4 rounds of that, and then put him on Alimta only. And then the mid-treatment scan showed that that was working and reducing things. And then the next scan showed that everything was stable, including the brain, which continues to be stable. But he was, the stuff in the bones, although there was nothing new, was larger. So that's what's causing him a lot of pain. And that's why he's not here tonight, because frankly, I don't know if I can say this on TV, but he just can't sit on his ass that long. So he's having a lot of pain in the bones. And so after review by the tumor board about 2 weeks ago, they are adding Avastin to his chemo mix. And he will start radiation to his pelvic bones this Thursday. It'll be every day for 2 weeks. So we're hoping that that will give him pain relief. That is really just for pain relief, not to stop the spread of the cancer. Hopefully the new chemo combo will do that. But that's where he is so far. And for those of you that asked, the wedding was amazing. Dave made it through. It was great. And you can ask me more later.
Thank you. And Dave, we're thinking about you. We wish you were here, buddy.
Yeah.
Okay, we're going back and forth.
Yeah, we're random.
Tonight.
It's a new group up here, so we're going to do it however we want.
Okay, I'm Joanne, and my husband Ron is usually with me. He will be here later. We had to divide and conquer tonight. We have a grandson in the championship game of the Little League All-Stars.
That's exciting.
Very important. Anyway, I want to do what Tina did and say how I came to Addario, or I'm having trouble getting used to that, but I will. I came through Jackie McNamara, who's a sorority sister of mine, and she is still, she doesn't come to the living room any longer, but she's always online, and she has been a mentor to me through this whole thing. And she said, when in the days of the diagnosis and what the treatment's going to be and what the genomic testing shows, she steered me to the foundation, and I've been coming since November 2016. I was actually diagnosed in September 2016 after a year of misdiagnosis of a cough that was misdiagnosed as postnasal drip, as allergies, as the gas thing. The word isn't coming to me. Yeah, exactly. When I was finally diagnosed as lung cancer, it turned out to be stage 4 adenocarcinoma with the EGFR mutation. So I was put on Tarceva, which worked well for 2 years. What it did to me I did have some rash like David, not as severe as his, but what happened to me is I got the head scabs. And as a result, toward the end of the second year, my head was like it had a helmet on it. When I changed to Tagrisso, the scabs went away, but the hair went with it. And so, clump by clump. Anyway, that was almost a year ago, and the hair is coming back, as you can notice. Anyway, toward the end of the 2 years, about the 23-month point, a study that I am still in, at Natera, blood biopsy to show progression through the presence of circulating tumor DNA, showed that my circulating tumor DNA was going up. So Dr. Blakely ordered the further test, and that name is escaping me too. Anyway, to determine what it was, and it was the T790M. So I've been on Tagrisso now for 9 months, and I'm still having every 3 months blood tests at Natera, and it's still showing 0 circulating tumor DNA. And I just had 6 months CT scan and MRI, and they were clear. Well, not clear, stable. Apparently this mass, whatever's left of it in my middle lobe, is never going to disappear, but nothing's changed.
That's great.
And that's me.
I'm Rick, and I'm Tina's husband. And all I want to do is wish all the fathers in the room a happy belated Father's Day.
Thank you, sir. I'll go over. Go this way. All right.
Hi, I'm Sally, and I entered the IL-CAP test study, International Early Lung Cancer Assessment Project. I never get it all straight. Anyway, about 15 years ago, and I was at high risk, and this was to see if low-dose CAT scans would find a tumor before a regular X-ray could. And they found nodules in all my lobes. I had a family history. My mother had it 3 times. Her brother had it, and my paternal grandfather had it. And I'd been a smoker, although I had quit quite a few years before. So that's why I entered this study. I thought if I'm going to get it, I'd just as soon get caught early. And about 5 years into the study, one of the lobes grew, and I had surgery. I had my lower right lobe removed, and I still have nodules, and they've grown a little bit, not enough to be worrisome, and I'm 10 and a half years now, so.
Great.
So I am Surinder Batra, and this is my first time here. I am a caregiver to my wife. She was diagnosed with lung cancer about a year ago. She was diagnosed by accident. She was having insomnia for 3-4 nights. She could not sleep at all. So when we went to the doctor, they checked her lungs, and one of the lungs did not respond at all. So they discovered that X-ray, CT scan, that she had pleural effusion, a significant amount. They drained 1.3 liters 1 week, and 2 weeks later, another 1 liter. But when they tested the fluid, they said she had EGFR mutation. She had some other ROS1 as well, but they thought EGFR was the dominant, so they started treatment with Tagrisso. So she has been stable since, but a number of side effects have been very bothersome. More recently, the fluid appeared again, so they drained in April of this year. After that, we have been experiencing shortness of breath, and it could be because of the lung cancer, or she had been diagnosed with asthma for about 2 years prior to the lung cancer. So we are still not sure which one is really the cause at this time. But she's generally stable and resting at this time.
Thank you. Glad to have you here. Well, we can start out. Why don't we go over here? We'll do the outer ring next. Yeah. Yeah.
Hi there, my name is Jennifer, and I'm stage 4 lung cancer also. I have EGFR exon 20. I said 19 last time. Exon 20 and PD-L1 also. I had 3 Mets to the brain, and I'm down to just 1 piece of scar tissue after 1 treatment of SRS radiation, which is great. I was diagnosed in August of 2018, so I'm just coming up on a year. Currently on Keytruda and Alipna, and that's working well. I just had a scan a couple weeks ago, and I'm still responding well, and no progression, and everything is still shrinking. So other than just having had chemo on Friday, I'm feeling pretty good.
Glad you could be.
Yes, I'm glad to be here too.
Hi, I'm Nicole Stone, and I was diagnosed on September 1st of 2018. I have stage 4 non-small cell, and I'm EGFR positive. I've also learned that it is hereditary, and so it's, how do you say, gremlin?
Germline?
Germline, okay. Germline?
Yep.
Okay, and so I hear that it's very rare, so yay. I also, the cancer metastasized to my brain. There were 4 tumors, went to my liver, my bones, and 1 in my breast. A month after I was diagnosed, I had brain surgery to remove one of the tumors that was pushing on my nerves, and it was causing me to have a stroke. And so they removed that one, and we've been on Tagresso for about 8 months. And recently, I just found out that there's a new tumor in my lungs, and they're calling it a resistance tumor. So I had a biopsy on Monday, and they say 3 to 4 weeks until I find out what that genetic makeup would be and what direction we're going to go from there. They've presented a clinical trial for me to get familiar with, so if that's the right direction, then I'm sure I will go that way.
Yeah.
There's anything else in my notes? Let's see. I've had a couple radiations in my hips for the bones and then for my lungs. But that's about it, and that's me.
Let us know what you find out, and certainly stay in touch with Michelle and others so we can help. Okay, all right. You're in good hands.
Hi, I'm Judy. I'm here as one of Nicole's caregivers, and I just wanted to come here and support her, and to find out a little bit more, I guess, about other lung cancer patients, so that I can be a better supporter for her. She's always been our #1 cheerleader for all of our friends and families, and so I just want to pay back that favor and be the best caregiver that I can be.
Thank you.
Thanks.
Hello, my name is Francis Spuit. I was diagnosed in December of 2007, so I'm at 11 years non-small cell, stage 1B. I've had right upper lobectomy and 4 rounds of chemotherapy. I'm more familiar with some of you for my advocacy that I've done a few times in DC. It's going to be next month in Washington, D.C. We're going to create some noise, knock on doors, ask for money, make sure that we get both the respect as well as the money that lung cancer deserves. I'll do that with, last time I was there, actually the California delegation had 3. now we're having 2 teams that go out there in Northern California and Southern California. I hope to see some of you out there as well. I think you were there.
We'll have a large team there in DC for the National Advocacy Summit if you couldn't hear him. So yeah, it's important work, and thank you for your help and participation.
And I think the registration's open for about another week. So if you can go to our website, you can learn more about the summit and hopefully register and join us. We could always use more in California and other places as well. Yeah.
Hello, everybody. My name is Aloy, and I'm here for support for my husband, Eric.
Hey, everyone. It's been a while since I've been here. I've been diagnosed 6 years ago, first time around. Stage 3A adenocarcinoma at the age of 30. Had a lobectomy, chemo, etoposide and cisplatin, and radiation, and was cool. Was doing great until about 2 weeks ago when they found a recurrence. So that's where I'm at now. Actually, a week from today, I'll be having surgery to pop out 3 lymph nodes that are lighting up in the middle of my chest. So we're going to hope to just get those suckers out and get me back on the road to healthy living, staying positive, staying strong. It's not my first rodeo, so I have a lot more hope at this time around than the first time. Bonnie was a huge help for me the first time around. I was basically had given up after everything I had heard. I wasn't in touch with anybody. There's no statistics on someone getting this at my age. You know, it was really hopeless, but Bonnie and coming here was super helpful in giving me some of that hope and knowing that there's a chance that we could live through this thing and beyond it. So also met Francis at the Advocacy Summit years ago, and probably can't go this year as it's a little close to my surgery date, but I highly suggest it for everyone that can go. It's hugely impactful and a great thing for you all to get involved in. Get some FaceTime in DC and rattle some cages. So,
Thank you. Let us know how it goes.
Yeah.
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 Thank you. Can I start with you? Work away that way. Thank you.
Oh. Yeah.
Yep.
Yeah.
Okay.
Hi. This is my first time here. My name is Ivica Milicevic. I'm here with my daughter, who has been coming here for a while because I was not feeling well. But I will refer to her to explain my situation.
Hi, everyone. I'm Katarina, as many of you know. So she was diagnosed November 2018, somewhat by accident. She had been babysitting my niece who had croup, and then she developed a cough and went to the doctor, who sort of intuitively felt like the cough sounded strange and immediately just ordered a test. So within 5 days, we knew. So she was diagnosed with stage 4 non-small cell adenocarcinoma with PD-L1 5%, negative for EFGR, ROS1, ALK. She did 4 rounds of carboplatin, Alimtan, Keytruda, and then we did the maintenance of Alimtan, Keytruda. The first 2 scans showed stability, no progression, no shrinkage, but the last scan at the end of April showed subtle growth. So we've been in the process of discussing the next step. She has a biopsy tomorrow for part of the screening, or not part of the screening. She's doing screening for the Nectar clinical trial, which will likely start in about 10 days. And the biopsy is part of that, but we also want to look at a mutation that kind of came up in the blood biopsy that Amy has been helping us understand. And yeah, that's kind of where we're at now, is the clinical trial and seeing where that takes us.
My name is Fred Palmer. I was diagnosed with non-small cell lung cancer in October of 2013. My last course of treatment was immunotherapy, which ended in September. And so far, I'm stable, and there's been no progression appearing on PET scans. I'm also involved in the Natera clinical trial, which is to monitor for any progression with a blood biopsy.
Hi, I'm Rick Bryson. I was diagnosed in February of 2015, stage 4 adenocarcinoma. I did not have any of the genetic mutations, so I was going down the path of straight chemo. I started with carboplatin and Alimta, and went through 4 cycles of that. And that was really effective. It took care of my lung tumor and my lymph node tumors. And then I was on Alimta only for maintenance. After a couple months, my adrenal gland tumor progressed. And since that was the only active tumor, they were able to surgically remove it. I did a little bit of radiation and then was on just another couple months of another type of chemo until February of 2016, and I had my first clean scan. And so that was over 3.5 years ago, and I've been NED ever since and been really thankful. Tina introduced me to come to the Addario Foundation through the Stanford lung cancer support group that meets first Wednesday of every month. And so now, what I'm doing is I ended up just retiring, and because work got too hectic with the schedule and everything, and so I get to volunteer and go visit my kids in Idaho and Washington State and do all the projects that they leave for their dad. I did have one complication after my chemo ended, and that was 6 months after I stopped taking Lovenox, which is a blood thinner. I ended up getting a DVT blood clot in my thigh that was pretty extensive. It went from my knee to my groin. Wow. And they had to go take that out and insert a stent. And when at the end of that process, when I was in recovery, they determined that I was I had an acute appendicitis. So I came out of recovery and went right back into surgery, and they laparoscopically removed that. But since then, I've been pretty healthy, just going through the usual old age kind of aches and pains and things like that. So it's good to be here.
Good to have you.
My name is Ziva, and this is the first time I've been here. And I was diagnosed a year ago, and a friend of mine told me about this a year ago, but this is the first time I've ever been in public saying that I have lung cancer. So my heart's really beating. I'm so happy to hear the stories so far. They just, I've really never met a patient that has lung cancer, I realized, until I met him. And that gives me hope, because you all look so healthy. And so I felt sick about 8 or 9 years before I was diagnosed. My feet were weird, the color of my skin was weird, I couldn't sleep, I was very anxious, and I'd have blood tests, but they couldn't find anything. And then, then I couldn't even, think very well for a few months. And then I went in to the doctor, and she had me have an x-ray, and she thought it was pneumonia. So for a month I was on antibiotics. And that was, anyway, that's a long story about that. But, and then I found out that I could take Tagrisso. So that's been, I guess they said, I was really lucky for that. I've been pretty good, feeling pretty good. And then the original tumor grew. So it was suggested that I have radiation. Someone else said maybe a biopsy, and so I've been going through craziness around that. And then today I figured radiation. When I talked to the radiologist, and I thought, well, when we talked, he's going to do a lower dose than the normal 10 every time. So anyway, I guess that's about it, unless you can remember some more stuff I forgot.
Hi, I'm Jim. I'm Ziva's husband, and I do want to, commend all of you very brave people here who are very encouraging. Ziva is stage 4, and she does have an EGFR mutation with a 19 deletion. And I think you summed it up pretty well. Yeah.
The thing I didn't say is
Oh, to start with, she had, they thought 3 lesions in her brain. When they did the scan, there turned out to be 5. And before the genetic testing results were back, she had stereotactic radiation too, and as they planned for that, they discovered 5. 2 are not detectable anymore, and the other 3 are stable. Her liver was saturated. Too many to count was the description at the time. And Tagrisso has reversed seemingly all of her metastatic cancer. It's just her original tumor has, they couldn't decide if it was remaining the same or it was growing at the 3rd check, so we're 9 months in. They decided it was growing a little bit, and that was the motivation to radiate that with the goal of being able to keep her on Tagrisso for longer.
And I start that next week.
Mm-hmm. Yeah, it was actually kind of, I love the internet today. Your email to say, hey, join us if you can. We were going out the door, literally this morning we were here on the peninsula to meet with the radiologist and decided just to stay and come on down. And so we're so happy to meet all of you and be here together.
Well, glad you could make it. And as we say, sorry it has to be under these circumstances that we meet people, but we're glad you found us, and we're glad to have you here. And hopefully you'll be able to continue to come and share your story and inspire others like you've been today. So thank you.
Yeah, hi. My name is Nitin Patkar, and I'm here with my wife and my daughter. And I guess our story is that my mother-in-law was diagnosed with lung cancer probably about 9 months ago. And about 4 or 5 months ago, my wife was diagnosed with lung cancer too. So in the case of my mother-in-law, they have not been able to find any mutations, and they are treating her with kind of the 3-drug, which is now down to 2-drug chemotherapy. In the case of my wife, they were able to find an ALK mutation, and so she was treated initially with alectinib, which worked really well for about a month or so. Well, one thing I guess I forgot to mention that she also has had brain mets, and there were a fairly large number of lesions in the brain. So radiation, other than whole brain radiation, was not an option, and really didn't want to go through that. After about a month on alectinib, she had a very bad reaction to it. And so now they stopped it for a little while, and now she is on another drug called Alunbrig. That seems to be working pretty well. She's been on it for about 3 months. And so far, all the scans seem to show, I shouldn't say progression, but better results. And so we are hoping this continues. And so we are very glad to be here. And it's really good to be educated and listen to all of you. Thank you.
You can still say hello. You don't have to pass. You can say hi.
My name is Ken, and I'm a caretaker for my mom. She's stage 4 at EGFR, and she came here over 2.5 years ago, and then Michelle explained everything in the conference room. So really had no idea, and then she got us set up, and I think that was when we had gotten the biopsy, and then she set us up with the foundation testing, and then that directed the medication and for the results from that. And then right now she's my mom's got her Guardant, and it's still negative and no change. So everything Michelle said came true.
That's great.
So pretty lucky, yeah.
Hi, I'm Pat Pritchard, and this is my 3rd meeting. The first time, I think I was either in a coma or just plain shocked, because it was the day I received the news that I did have 2 kinds of cancer, 1 in each lung. Everybody's got to be different, I guess. So I was treated with radiation, and it wasn't bad. It was a lot easier than the chemo I did 15 years ago for cancer of the appendix. And this summer, by the way, my nephew also had cancer of the appendix, and it's apparently pretty rare, but you got to wonder if it's in a family. My sister, the mother of that child, it was really hard for her to do a colonoscopy, but she made it after failing twice. I am in a holding pattern, stage 1 lung cancer. I'm going to the Sequoia Y on the Live Well, Live Strong program, and I don't know what I should be doing for myself. Waiting is the hardest thing I have to do. I'm not a patient person. So I just figure, okay, I'll just keep doing healthy things till the next scan, which is in 6 weeks, and then I'll find out, did that radiation work, or were there false positives? In the meantime, I would love to hear that these drug companies, I wrote down Tarceva, Tagresso, Ellipta, Labanex, Electina, Olympric. Anyway, I wish they would do more in the light of diagnosis and take at least half their advertising money and put it into the science, because it's awful to hear that somebody has stage 4 lung cancer. I was stage 1, and it was incidental to, oh, you have to get a lung x-ray or we can't renew all your allergy meds and inhalers and things with COPD and severe allergies and asthma and stuff. So thank you, but let's prevent more people from having to be here. We can party.
And drink more wine.
Hi, I'm Azita Taylor. I'm with Bristol Myers Squibb and patient advocate. Thank you for letting us
Thanks
speak.
for coming.
I think I'm the only Bonnie here tonight. She's not here. So I'm Bonnie. I'm also with Bristol Myers Squibb, a patient advocate. Thank you.
Hi, I'm Patrick Noiza. I'm also with Bristol Myers Squibb.
Welcome.
Hi, I'm Evangeline. Good evening. I've been coming here to this living room since August of last year, and I'm very thankful I found this family, which I call my second family, because it has really given me hope, and it changed really my outlook on having this illness. With that word hope, it really gave me courage and given me hope, because when I was diagnosed March 13, 2017, I was really fighting and in denial, because I was never a smoker and I always questioned why I had this. I was diagnosed non-small cell lung cancer, adenocarcinoma, and then after almost a month, at first I thought I will have lobectomy, because it showed that on the PET scan, it's only contained on my upper left lobe. So I was scheduled for a surgery April 27th, but day before surgery, the surgeon ordered an MRI of my head. And I said, why? Because I'm already prepared. I had my pre-op exam, and the nurse said, oh, just for precautions, or we want you to, I don't know. So day before surgery, I had an MRI of my head, and they found an 8-millimeter tumor on my right brain and 12-millimeter tumor on the left bone of my skull. And so the surgery was canceled the following day, and my surgeon oncologist called for a meeting the following week, and I was referred to a medical oncologist in Stanford, and that's Dr. Neil, who will be here in September, I heard. Anyway, so I was diagnosed, I was categorized stage 4 on April 27th, and that really was, it was devastation. Anyway, so I was put on, I was EGFR positive, and I was put on immediately on Tarceva. I had and then I had cyberknife radiation on my on my right brain, in which after 11 weeks, the tumor shrunk on my right brain, as well as after 11 weeks of starting Tarceva, the tumor on my upper left lobe shrunk by 1 centimeter, and I was stable for 24 months. But December of last year, after the MRI and the CAT scan, the tumor on my right brain increased in size again, as well as on my lung. And so I went through the T790 mutation blood work, in which it failed twice. They couldn't find. I don't know. The doctor said I might not be EGFR positive anymore. But I said, is there any other option? So he decided it's between I'll have a bronchoscopy or CT scan needle, CT guided needle, so biopsy. So I went to the CT needle biopsy, and they found out I am EGFR positive again, so I was immediately put on Tagrisso. So I started the Tagrisso April 27th, and so far the side effect is it's giving me headaches, but less. But I said, I'm not complaining, I'll bear the pain instead of having the diarrhea, in which in Tarceva I always have diarrhea like 5 days a week. So I guess Tagrisso is better for me. So, and I'm scheduled again for another MRI in July and a CAT scan. So I'm being monitored every 3 months for how the outcome would be with the Tagrisso.
Hi, I'm Karen. I am actually an 11-year survivor. I had a tumor in my upper left lobe, which was found accidentally. And they were so confident from the CT scan that they said, we're not even going to do a biopsy. I went right to surgery. And after surgery, after a long discussion, I decided to go ahead and have chemo. I didn't need radiation as sort of an insurance policy. So I've been very fortunate to have gone through all that and take care of it. And now I'm here in just giving as much support to this organization as I can and helping anybody that I can. So thank you.
Thanks, Karen.
Hi, I'm Jason Yanahiro, and I'm an advocate, and I'm really happy to be here and hear all the testimonies here, so I appreciate everyone sharing. Thanks, Lee.
Hi, I'm Ebby. Is this live?
Yeah,
it's live. Okay. Anyway, I've been coming since 2011. From 2011 to 2015, I came with my husband Neil, who had stage 4 EGFR, and I was his caregiver throughout that time. And he passed in 2015, July 29th. 2015, so we're coming up on 4 years now. And now I'm back because I was diagnosed with stage 1 EGFR adenocarcinoma a year ago. And I'll be celebrating my surgery on June 19th, and I am NED, and I'm very, very fortunate. They found it. It was a purely incidental finding. For another test, so I was very, very fortunate. So I've been on both sides of the bridge, so to speak, the caregiver with someone with stage 4, and then myself as the patient with someone with stage 1. The one constant throughout it, obviously, is we were both. It's very odd that two people in the same house would have it in EGFR. But the one really wonderful constant throughout it has been that Dr. Wakelee was my husband's physician and mine as well. So we were both under excellent care. And I would just like to say the very, very first time that we saw Dr. Wakelee was on June 30th, 2011. It was our 37th wedding anniversary. And we were so happy that we had gotten in to see her. So I'm really glad that she's here tonight. And I'm happy that everybody else is here as well.
Thanks, Ed. Anybody else want to share that we missed? I know a few people were snuck in the back. No, we're good? All right. Well, thank you, everybody, for that. You were mentioning, first time talking about lung cancer in a space, and I've got to say, I think I've heard that from so many of the people in the room who've come here and for the first time, and it's a shame that more people aren't able to feel comfortable to really be able out there talking about a lung cancer diagnosis, and certainly the stigma plays a role with that. But the truth of the matter is it ties a little bit into today's topic, and the truth of the matter is what's happening in the lung cancer space is really changing the paradigms for a lot of other cancers and what's taking place in the research world. And really, it's people like all of you who are participating in trials, who are taking immunotherapy or TKIs or other things, and it's now trickling down into other places and other spaces. And we'll talk about a lot of those things. But before I have Professor Wakelee introduce herself, I just want to give you my personal story and why this topic is so relevant to me today and why I was excited about being the one who happened to be able to want to moderate the panel. So 19 years ago, January to be exact, my father was diagnosed with late-stage renal cell or kidney cancer, and unfortunately ended up passing away 4 months after his diagnosis. And at the time, when we spoke to the physicians about what our options, it was maybe chemotherapy, but it's already spread, so that's doubtful. Anti-angiogenesis was kind of an idea that they were talking about. There was one trial taking place, but the truth of the matter is there wasn't any hope for my dad. There just wasn't, and we recognized that, and he passed away 4 months later. I did not work in this space at the time. I was in the for-profit world, and his passing really drove me to change what I did for a living. So I ended up coming back from his funeral. I quit my job, and I went to go work for the American Cancer Society, and I've been working in this space for 19 years. Strangely enough, in November of 2017, my second oldest brother was in a motorcycle accident, pretty horrific, and we were worried about the motorcycle accident and if he'd make it through the night. And after about 4 days where it looked like he was going to make it, the doctor came in and said, "Good news, your brother's going to be okay. He'll probably walk. He won't have brain damage. He has an 11-centimeter tumor on his kidney." So, same thing my father had been diagnosed with. 19 years ago, I knew absolutely nothing and had no way to help my family. And so to be able to help my brother and go through his treatment journey with him has really been quite different, not only because of my knowledge base, but because every conversation with the physician revolved around things that happened in the lung cancer space. Now, in some cases, the physician knew, and in some cases, I was educating the physician about what takes place. They didn't plan on ordering molecular testing. We changed that. They didn't know what the results meant about TMB and other things. We changed that. They really weren't aware that immunotherapy had just been approved in April, a month after his surgery, as the treatment in case his disease had spread. So here we are in a cancer space, renal cell carcinoma, where 19 years ago, not much hope. Brother's diagnosed, and now every single piece of his treatment journey has come directly out of the work that's taken place in the lung cancer space. It's pretty incredible when you think about that. And just to put a kind of fine point on that story, there were originally 3 spots after his surgery in his lungs, 1 on his liver, so they were concerned it had metastasized. They've followed all those spots for a year. His most recent scan was completely clean, so no evidence of disease. And because he is a LeDuc, like the rest of us, he celebrated by going out and buying another motorcycle. He says it saved his life ultimately, so he figured that was his reward for being 1 year clean. I've just told him to wear a helmet because even though we have hard heads and it saved him the first time, probably best not to take another chance. So that was why I was excited to hear about this topic. And what we're hoping to do is make it a discussion not only about how lung cancer's treatment has really changed the paradigm. There's things taking place outside of lung cancer that look very promising, and there's going to be some learnings there. And then outside of just the treatment paradigm, there's really a lot of things that all of you touched on today that are going to be brand new to people in other cancers. And so part of the thing I want to talk about today is how do we as a community help drive that change and make it to where others don't have to go through this long education process. So maybe it's a bit easier, and the next time someone with renal cell carcinoma sees one of those doctors, it isn't what's testing, and what do you mean a targeted therapy is available, and what do you mean there's immunotherapy? Hopefully our knowledge will trickle down and share. So that's kind of the basis and genesis for this. And with that, I'm going to turn it over. And traditionally we used to kind of introduce and read the bio, and we've gotten away from reading the bio for this. And so what we've done now is ask the moderators and our panelists to kind of introduce themselves and tell us why lung cancer is important to you, and then we'll move into the dialogue between you and Amy here, and you guys can take it from there.
Great. Well, it's always great to be here and to many familiar faces and a lot of new folks. And so first, just want to thank you all for being willing to share your stories. I think the lung cancer remains something, and I think cancer in general, it's a private thing to have cancer. Some people are able to then make it more of a public thing by making it more public. It helps many other people as well. With lung cancer in particular, there certainly is a stigma. Nice to see that sort of changing a little bit. But there's still this issue of when someone's diagnosed with a serious illness, it can change the relationship with so many different people who are in your lives. And I think that's one of the reasons people are often a little afraid to talk about it. They just, most people, I just want to still be me, even though I happen to have this illness. And that's something really talk a lot about with my patients. And to be able to be here with so many people who are willing to speak out and, be a part of the bigger lung cancer community is always very inspiring. So thank you all for being willing to do that and to talk about being part of the work in DC and raising the voice even louder about it. So I've been treating lung cancer. I'm not necessarily going to disclose my HR, but so when I started in medical school, I knew I wanted to be an internal medicine doctor, and then I realized that I really wanted to be an oncologist. And the inspiration for being an oncologist was the inspiration from the patients I met when I was going through that rotation, and how so many people, once they had the diagnosis, were able to live life a bit more fully. And I know that, for those of you who've been on this journey for a while, I think many of you probably understand what I'm talking about. And for those a little bit newer, sometimes it's like, what do you mean? But it's this ability to sort of, when so many of us go through life just sprinting because there's so much we're always worrying about this, worrying about that. And when you have a cancer diagnosis, it really forces you to sort of step back and say, I'm alive right now. What's important, what's meaningful, and how do I make sure I continue that focus on that, even though I've got this huge issue to deal with that I never really expected to have to deal with. And so for me as a medical student, meeting people who are able to grasp that and really live, I found really inspiring, and also inspired me to want to help the patients who were struggling with that and not quite able to see that side of it a little bit more. And so that was something that I've carried with me since medical school. At the time, I didn't know I wanted to be a lung cancer specialist, but I knew I wanted to be an oncologist. And once I graduated from medical school and started off at Stanford, I think they knew I wanted to be an oncologist. So my very first day, I was on the oncology inpatient wards in the hospital. I showed up a little late because they gave me the time wrong, but we got over that. And I really felt like, wow, this is really what I want to be doing. These are the people I want to be helping. And it's also the community of people who are taking care of patients living with cancer. Some of it's physicians, but nurses, now advocates. There weren't as many advocates back then. It wasn't something people thought about as much, but sort of the whole team, all the people working together, just most people going into that field, it's just really good people, and so it's a great environment to be a part of. The journey into lung cancer happened in fellowship. For those of you who don't know about medical training, we go through medical school for 4 years, and then you go into one of the big fields. So you're a surgeon or psychiatrist or internal medicine or pediatrics. So you do that for 3 or 4 years. And then in internal medicine, if you want to be then an oncologist or a cardiologist or something, then you do more years. So it's 3 more years. So, and it was in my oncology training that I realized lung cancer was what I really wanted to work on. And back then, we really didn't have a lot to offer. We if you found it early, there was surgery. And at the time, if someone had surgery, we didn't do anything after. We didn't know that we could help more people be cured with chemotherapy or any other treatments. And if someone had metastatic disease, we really just had chemo. We didn't have targeted treatments. We didn't have immune therapy. That was all there was. And so it was this realization that, wow, this is a group of patients that really needs more. They need more help. And it was something where I felt like that was an okay fit for me. And there also wasn't anyone focused on it at Stanford at the time. So it gave me a chance to build up a program so that we could offer trials to patients who came in with any kind of stage of disease. And at that time, it was just all lung cancer. We didn't even separate it out by adenocarcinoma versus squamous carcinoma. I mean, we had small cell and non-small cell, and that was it. And then we had the chemotherapy. So it was definitely a feeling of like, wow, there's so much that we need to be able to do to offer to these patients who are dealing with this illness. And also, like I said, there really weren't a lot of people as excited about it, but I had an opportunity to go to some conferences, and I was able to meet other people working in lung cancer. And at the time, because we didn't have a lot of exciting things to do, the people in the field were really dedicated to helping their patients with the disease. And I realized this was my field when I was fortunately invited to be part of a conference that happened to be in Hawaii, so that part was nice. But I realized that I actually wanted to be in the lectures and not out on the beach, because it was really interesting to hear what others were doing to help people with lung cancer. And then things got really exciting. So that was my foray into it, and I was able to build up the program at Stanford. And now I have 6 wonderful colleagues who are medical oncologists. We've got 5 surgeons and radiation oncologists. You've heard Dr. Neal's name come up a few times. He is coming here in September, and he's fabulous. And Dr. Prado, Dr. Ramchandran, Dr. Das. It's a great team. And so wonderful people that I'm working with, and then wonderful nurse practitioners and nurses, and I mean, just a whole group of folks. But we also now have so many more things we can offer to our patients. And so I remember kind of first learning about these drugs, this EGFR targeted drugs, and going to the first presentation with the drug gefitinib, also called Iressa. And at the time, we didn't know about the EGFR mutations. We just knew that these drugs, if you gave them to people, about 10% of lung cancer patients had phenomenal responses. It was like, wow, that's great. And so we were trying to figure out, can we give this with chemo, and looking at it in other cancers, colon cancer, different diseases. And then this papers came out showing, well, actually, the reason that this certain percentage of patients respond is because if you test their cancer, you can find a mutation, a change in the DNA in just the tumor, but not in the rest of the person, in the EGFR. And if they found that, those are the people that responded. And if you didn't, those people didn't. And then there was this IPASS trial where, based on the earlier information, that this 10% of people, and the 10% happened to be mostly people who hadn't smoked who got lung cancer, and happened to be, at least in the earlier trials, more Asian and mostly women. And so there was a study done comparing this drug, EGFR drug, versus chemo in a group of patients who were non-smokers. The study was done in Asia. They happened to mostly be women. And the results came out, and it was kind of confusing until they went back and did the testing and separated out, this is the group that has the EGFR mutation, and this is the group that didn't, but happened to have all those other characteristics. And when that analysis was done, it was really clear that if the mutation was there, it was much better to get that EGFR targeted drug versus the chemo. And if you didn't have it, it was not a good idea to get the EGFR drug. And so that was when we just shifted the way we thought about lung cancer, and decided, oh, okay, we have to test. Because I need to know if someone has this EGFR mutation, because that's how I could best help that person treat their disease. And so that was that really changed the way we thought about treating lung cancer. Now, in other kinds of cancers, they had already known about that, but for very small numbers. So there were some of the liquid cancers, they knew about particular mutations that were found every single time there were particular, like CML. That if someone had this kind of chronic leukemia, CML, they almost always had the exact same mutation. And so that was one of the first things that we could target. So that was really, that made sense. And in lung cancer, we realized, well, okay, we can find this specific gene mutation in about 10% of all cancer patients with lung cancer. What about that other 90%? right? And that really then started the wave of understanding. So then in 2007 was when ALK was discovered. So ALK stands for anaplastic lymphoma kinase. So it's actually not just in lung cancer, it's actually in some other types of cancers as well. But researchers in Japan figured out that in like 5% or so of lung cancer, you could find this one gene, ALK gene, and then we learned what we did from EGFR, so is it the same in ALK? And sure enough, if you give an ALK drug, it's better than chemo, but you have to know that ALK is there. You can't just guess. And now, when we talk about it, it's not just EGFR and ALK. There's ROS and NTRK and BRAF and HER2, and the list goes on and on and on. And I was just in a meeting today with some of my colleagues, like research meeting, looking at, what we call we draw like a pie chart, right? And we kind of slice it up for the different mutations for the probability of finding one within any person with lung cancer. And when we first learned about EGFR, that was only 10%, so we had 90% when we didn't know. And then we added an ALK, and that was another 5%. And now we have only about 30% where we don't know. Now, some of the ones we know we can't always treat, but just at the American Society of Clinical Oncology, ASCO is our biggest meeting of the whole year. And there was some really exciting data about one part of that pie called KRAS, where we didn't have any treatments that worked before, and now we finally have the first drugs that are actually showing some activity. So it's sort of like that pie keeps, the parts that we don't know what to do, that keeps shrinking. And so that's the whole targeted treatment, and it's really exciting. What's also been exciting is if you start with the targeted treatment, it helps, and I think many of you shared your stories where it was working for some people a long time, for some people not as long. And then we talked about, well, if one EGFR drug stops working, then there's a different one that can work some of the time, but not always. And with ALK, there's 5 drugs. With EGFR now we have 5 drugs. With ROS, there's a couple drugs. The NTRK, there's a couple drugs. So we keep sort of adding to as we understand, well, when this drug stops working, what do we do next? And now we're also talking about adding chemo back in with the TKI drugs and anti-angiogenesis. So but this is the targeted world it's constantly evolving in our understanding of it. And so that's been really exciting from a lung cancer perspective of being able to be part of the research, but also more importantly, being able to help people specifically once we can understand what's going on with their tumors. So that was exciting. So more and more people now, wanting to work in lung cancer because there's so much we can do. Then all this immune therapy stuff came out, right? And I remember when I was in college, my first interest in medicine, I knew I wanted to be a doctor since I was like that big, but my interest in doing oncology, part of it was this idea that, hey, if we've got cancer, the immune system's supposed to recognize things that aren't supposed to be there. Why can't we get the immune system to better fight cancer? Now, I was not the only one with this idea, obviously, but I remember—
As a 5-year-old,
yeah, exactly. Yeah, no, this was in college, right? But I remember really thinking, wow, this has got to be something we can do. And when I was at medical school at Johns Hopkins, we talked to Drew Pardol. We were, talking about different ideas, and then, ended up getting busy with all the other things. And the targeted treatments was all exciting, but to come back to the immune therapy has been really phenomenal. And there again, so I talked about targeted treatment, and with lung cancer, we have much more understanding of specific drivers and treatments where we can really work there. There's some of that in other diseases, but it hasn't been quite as straightforward to understand. With immune therapy, it's also been something where lung cancer has not been the only disease that's been at the forefront. Melanoma has always been the one where we've had a bit more of an immune understanding, renal cell as well, with some earlier fairly toxic treatments that could sometimes get that immune system to, hey, that cancer is not like the rest of the body, let's go after it. And so as we finally were able to figure out some treatments that would work well to stimulate the immune system more broadly, it's been really fabulous to be at the forefront of that with lung cancer. And so when we talk about immune therapy, and I remember I think it was a living room like 2 or 3 years ago, I got to talk about immune treatment more. And I was the whole time, so I'll try to limit that a little bit. But it's this idea that in order for the immune system to attack the cancer, it has to be able to see the cancer as something different than the rest of the body. Because when a cancer develops, especially cancer with EGFR or some of these other drivers, oftentimes that's really the only gene that's different. So there's just one protein that's different that's causing it to be a cancer, and the rest of it looks like normal tissue. So that makes it pretty tough for the immune system to figure it out. Other cancers have a lot of mutations, and then it's a little easier for the immune system to recognize it. And then we also have to do things to stop the cancer from hiding and pretending it's normal. And one of the main ways it does that is this PD-1 or PD-L1. Some people have thrown that term out, right? So this is a protein that's on a lot of normal tissue that says, I'm normal, I'm just leave alone. And then the immune system, an immune cell comes in, if it sees that PD-L1, it says, oh, well, some of you looks a little bit different, but I guess if you have that PD-L1 signal, I know that it's normal and it goes away. And so if you block that, then you're blocking one of the hiding signals, one of the stop signals, so the immune cell can come in and kill the cancer. But it still has to be able to recognize the cancer as something different. So there's kind of two pieces of it. When these drugs were being developed that were blocking PD-L1, and PD-1 is kind of, it's the receptor versus the ligand, they're all very, very similar. The fear was, well, if that's the way that the cancer is hiding and saying I'm normal, if you block it, then what about all the normal cells that are also using that as a way to hide and be normal? And that was the fear that said it would set off all sorts of autoimmune problems. What's been really fortunate is that doesn't happen as often as we were worried about. And in fact, for many people, those drugs do make a big difference and can really allow the immune system to recognize the cancer, attack the cancer, and allow the patient to keep going and living without the disease causing the problems. But there's still a lot of challenges there. And in melanoma and some of the other cancers, we've been learning from that. But lung cancer was where we really learned that, hey, you actually can increase the effectiveness of those drugs by adding other things to it, not just immune stuff, but actually chemotherapy. And when the idea of adding chemotherapy plus immune therapy together was first introduced, there was a lot of concern because there's this perception that, well, chemotherapy is highly toxic and it's going to, erase the immune effect that you would hope to get from the immune treatment. But it turns out they actually work pretty well together. And radiation also can work pretty well with immune therapy. It's always on that edge of we don't want to set off too much immune reaction, but we need to get enough attack of the cancer, right? And so seeing that and that option to treat so many patients who were otherwise not having options as exciting as when we found the EGFR or ALK in the tumors, that's been fabulous too. And so now with lung cancer, when we think about treatments, we still have a chemotherapy, and it turns out chemotherapy is still the backbone, and as much as we talk about trying to move away from it, turns out chemotherapy can help the tyrosine kinase drugs, the targeted treatments maybe. That's been some of the new news that's been coming out recently. It also, we know, helps with immune therapy. That's been a new standard for a lot of patients as well. So we're not moving away from it. We're just trying to figure out how do we add everything together to really beat the cancer, but help each person feel as well as possible too. So it's always the balance of making sure we get the cancer, but without causing too many problems for the person. And so with lung cancer, we've been at the forefront of so much of that. And so now, it used to be, like I talked about when I started doing lung cancer at Stanford, I was like the only one, right? There were some people doing it, but they were told, well, you can treat this other disease, but only if you also treat lung cancer, right? And that was kind of the way it had gone until I started. And now when we get a new group of fellows coming in, I talked about how you go through your medical school, then residency, then fellowships for oncology. Actually, we get more than half of the fellows now want to work in lung cancer because they know that there's so many exciting things happening and so many things that they're going to be able to do to make a difference. And the recognition that lung cancer, unfortunately, still is one of, it's the second most common cancer. And so it's a huge problem. And there still are issues around the stigma where there isn't quite as much research focus as we'd like to see, but there is some of that. And before, I know I've been ranting for a while here, but let's go back. One more thing. I think that as exciting as all of these treatment options are for helping patients live longer, live better, feel well, we really want to step back too and get back to a comment that was raised earlier. We still want to be focusing on, we need to find the disease. We want to, first of all, be preventing the disease. And smoking cessation is a part of that for many people, but we also know lung cancer happens to a lot of people who have never smoked. And so quitting, having a lot of anti-smoking campaigns is really critical, but it doesn't get rid of lung cancer completely. And so understanding why people get lung cancer, smoking or not, is still really critical research that is being done by many, but there's a lot that we don't understand yet. And then being able to find it early. So you talked about IL-CAP, and there have been many screening studies trying to figure out, can we find lung cancer before it's metastatic? Can we find it when it's still in stage 1 or really small? And we know now from many trials that screening CT scans can find cancer early and can actually lead to more cures. But even in the US, where we've known that for a number of years, there's very, very little screening being done. And if you think about the rest of the world, where resources are a bigger problem in many places, it's not being done at all. So people are still finding their cancer only when it's not curable. I mean, I'm still hoping for cure, everybody in this room, right? And we're all still really striving towards that. And there are many, many people living far longer than they used to. But if we can find it when we can remove it, or ablate it, or radiate it, then that's going to lead to more cures. So we still got to be focusing on that too. And screening is something that goes across multiple cancers, so I think it relates to this topic today too as well. So this is a challenge where we know women get mammograms, and we know we're supposed to get our colonoscopies, but the screening for lung cancer is just not being adopted yet. And there is a lot of research being done on blood tests, other things that'll make it easier, but we've got a long way to go there still too, right? And then how do we take all the stuff we've learned in metastatic setting and change cure rates when it's found earlier? And that's a lot of research happening there also.
There's a lot to unpack
That's what I was thinking too. By the way, when we were talking about this topic, we were like, there's no way it's a 2-hour topic. There's no way. This is like a 4-day conference.
You know I can talk.
Yeah, this is like a 4-day conference because there's so much here, because it really does touch on screening and early detection. Why are people getting it? That can be done across tumor types to try and figure out those commonalities where immunotherapy and targeted therapy go next. There's so many, but I know you had some questions that you want to pose or some thoughts too.
Yeah, I mean, I want to kind of back it up to the first topic you addressed, which is targeted therapy. And it was exciting to go to ASCO and hear, the advances that are occurring in that space, and, in particular for KRAS. I mean, that is a major advance in the field, but we heard data on, new drug for ROS1. We heard, updates on studies for RET. So, the reality, I think, is that targeted therapies are extending, improving, saving lives. And now we have survivors. I mean, this room is filled with them. People who are living and doing well, and now have a seat at the table for driving research forward. And I think that's been an area where we have, had a lot of productive and meaningful relationships working with patient groups to, interact and have that dialogue to inform meaningful research. What's research that will advance the field? What's research that helps patients? And, just had a call today talking about how all these groups are coming together and uniting. And so I also had a conversation with Dr. Karen Kelly yesterday, just talking about the opportunity for kind of real world trials and engaging with patients on that front. And so we were thinking about what are ways that patients can be involved. It's certainly going to the advocacy summit, participating in our lung cancer registry. There are so many kind of easy ways for patients to be part of the solution now. What are your thoughts on, how that's working, how, we are seeing that in lung cancer, I think in particular, as we keep carving that pie into these different pieces, that each of those groups is really getting engaged. And how do you work with patients in your own research? Are you actively working with them?
So lots of questions in that, right? Lots of questions. So I'm gonna, the first part I wanna address is about the key role of patients and patient advocates, right? And I think it's, and again, to commend all of you for being here today, because it's about the awareness of the disease, about, there's the sort of the social support for people who are newly diagnosed and not knowing where to turn for information and not knowing what to do, and that feeling of hopelessness that many people have, and say, oh, wait, you also have this disease and you're doing okay, and maybe I'm going to be able to be okay too, and this is someone I can trust because they're going through the same thing I am, and they're hopefully not talking in medical jargon, or they're helping me to make sense of it. Now, you have to be careful too, because there are going to be nuances that might not be as well understood, but just to know that there are other people on that journey also is so critical. But then it's also taking what is known and being able to get it out there to people who maybe aren't here in the Bay Area, where we're surrounded by academic medical centers and where everybody knows to get at least 2 opinions, and to ask. But for someone who's in a remote place with an oncologist who is doing their best to stay up on everything, but they're having to know 20 different diseases. So they might not be able to be right there where, I'm very privileged that I can just narrow in on, just a couple of diseases, and so can really be an expert in that. But no one would want to come and ask my advice on breast cancer, because that's not something I do all the time anymore. Right. So, to be able to have advocates and support networks for people who are in the middle of a small place and can say, I just got this diagnosis, I'm so overwhelmed, have a network to reach out via the, it's so great having the internet and having ways that people can communicate about this knowledge. And also to give people a voice to advocate for themselves. So the testing, right? We talked about targeted treatment and how exciting it is and how many new treatment options we have, but if a tumor doesn't get tested, you don't know what's going on, and then you don't know how to help the patient the best way. And there's still a lot of places, some not even that far away, where the full testing isn't being done. And so I think that the patient advocate groups especially have been such a critical voice in raising that awareness and really pushing to tell, make sure people know this needs to be done. We're not able to give the best possible care to patients unless the patient knows what's going on with their tumor. And they're not going to know what's going on with their tumor unless they get the testing. And so to raise voices as advocates, as patients, as people living with this disease is often heard far more when it's just the doctor saying we have to do this testing, right? Because then they, well, yeah, of course you want to do the testing, right? But, it's like, no, we really need to understand how we best help people, right? And so that's been such a great thing. And I think one of the really critical things that's happened with all the strong advocacy voices is that the stigma of lung cancer is reducing, right? It's still there. Right. You still have patients where, I hear the story, they tell someone that they've been diagnosed, and instead of what can I do to help you, they get the, did you smoke? I mean, just ridiculous questions, right? And some of that's that I think it's people don't want to have to face it as, oh my goodness, this happened to you, it could happen to me. So they try to put in a distancing question, which is, often comes out as rather heartless. And then there's also, it's just that many people don't know how to deal with someone who's facing a serious illness, right? It's not just about cancer, it's not just about lung cancer, it's just oh my goodness, you have an illness, and I don't know how I'm gonna be able to process my own emotions around that, so I'm just gonna leave, right? You hear that sometimes. So these things come out, and I think by having people open to talking about their illness and about what's going on and about how they're doing, it enables other people to talk about it, and also helps, I think, people see, I'm still a person, I just happen to have this illness, and I can find other people where I can still have that normal kind of conversation where I'm not being seen as just the person with cancer. And I think by raising that awareness and doing programs like this and having people able to talk about it, that is so important also. And then to your other question about, well, from a research perspective, like what's the role there? I think that we really all have the same interest and motivation. We're all looking for how do we best help treat the cancer, keeping the person with the disease feeling as well as possible, right? And hopefully living as long as possible at the same time, right? So that's a common goal that everybody is sharing. And all research is really designed to be doing that. I think where the subtleties come in is how much is this biopsy gonna help the person and the science versus just the science, right? And how much is this extra scan gonna help the person and help the other people who might be then facing the same situation and balancing all of those things, right? Along with the idea of we always need to be thinking about, well, the patient who's on the trial is the person, right? It's always the patient's always a person, right? And how does that person then continue with their life in the context of being part of this treatment, right? And so it's weighing those things, and so making sure if you're in a situation where a trial's being designed and the people designing it aren't as mindful of those issues. Making sure that you're getting that voice in there too is really, really important. But it's also having people willing to say, I'm here today because I was on this treatment, which I'm only on because someone before me was willing to do a trial to figure out it worked. Or I'm here today because I was willing to be a part of a study and it worked for me. And also being able to say, I did a study, it didn't work, but this treatment, and then the next thing hopefully will, right? So it's balancing all of those different parts to it. So with all of my patients, try to have at each decision point an open discussion around, these are what we know works, and these are the things that we don't know if they're going to work or not, that we hope might be better, and try to weigh probabilities. But it's always about weighing probabilities because nobody really knows what's going to work or isn't going to work for a particular person. As much as we've learned and as many options as we have, there's still so many things we don't understand about each individual and how they're going to respond to toxicities of a treatment versus how their cancer is going to react and be hopefully treated by the disease, by the treatment, right? So it's the balance of those two things, and there's so many unknowns there.
There's a couple themes there that I want to kind of go down a little bit with you here that you talked about, and I'm going to ask you maybe to get a crystal ball a tiny bit here. You mentioned the community oncologist who is dealing with a lot of different cancers, and you mentioned testing. One of the things that I'm hopeful will happen as drugs get approved across tumor type based on genetic marker is that we'll see a need in the community setting for physicians to recognize that it's not just lung cancer that needs testing, that there's a variety of cancers that need testing because of what we're seeing with drugs being across tumor types, and that people maybe have an NTRK mutation across, I think, 6 or 7 different cancer types.
More than that.
More than that, yeah, right? RET is another one that we're seeing is across a lot. KRAS, you mentioned earlier, crosses a lot. So do you...
And ALK, and I mean,
ALK,
many
exactly,
of
right?
them, yeah.
So do you think, in looking at the landscape with what's happening in the lung cancer space, and that these drugs have been approved in lung cancer, they're now starting to show efficacy or effectiveness in other cancers, do you think that physicians in the community setting are now going to become more aware of the need to test, and we may see an uptick in just people testing?
I hope so. And I think it's also important to raise awareness that it's not just about the clinicians not ordering the test, it's about insurance not always covering it. And that's actually been it's an incredibly frustrating situation we're in right now, where there are a lot of barriers to getting testing from a financial perspective. If a mutation is found in a tumor and there's a drug available, usually that can be covered. But getting the testing done and having that covered, there's still a lot of issues with that. And we grapple with it even at Stanford. I mean, we do pretty extensive testing for our patients, but we're often having to make a lot of phone calls to get the authorization to do that. And in some of the community centers where, we're in a big, big place, right? So, one of the advantages of being in academics is I don't have to think about the dollars and cents too much of it. I can, go at it from what's the best thing for my patient, knowing that there's a whole team of folks who are behind me to fight with the insurance companies and deal with, all of that stuff. But if you're in a small practice, you could bankrupt your practice, right? If you're in a small hospital, if you're not going to get that test covered, as much as you know it's the right thing to do, you can't necessarily do it. And so until we get policy changes that are more in line with, no, this testing is critical because you're not giving the best care to a patient without knowing what's going on, we're going to be thwarted. So some of the doctors, it's not that they don't want to do the testing. It's just that they're limited.
So from a payer perspective, do you think that now that more cancers are really needing this type of testing? Again, looking in a crystal ball a bit, do you think that story is one that'll be compelling enough to maybe move the needle on reimbursement rates?
I hope so. And that's where the patient voices are so critical also. I think that if a policymaker has a real person in front of them, it's like, I have this disease and I only am on this treatment because I got my testing done. That's a little bit of a different story than when we're saying that we do the testing, right? It's raising the voices, all of us raising our voices together to say it's not okay not to test. It needs to be done because we're otherwise denying people the best care, right? So that's one of the key things that I think is ongoing right now is raising those discussions. the hope is that now that there is awareness that, if you find BRAF, it changes what you do for melanoma, for lung cancer, and a few others. If you find KRAS, it changes in different ways for different diseases. NTRK, if you find it, then you've got a treatment that seems similarly fabulous across multiple different diseases, right? And so what's interesting is that there is more of an awareness in lung cancer, and so we are finding more mutations because we're looking more and being able to help more people that way. But if you couldn't have it be, it's just all cancers. I would love to see a day where, we don't have to do this at all because there's no more cancer, but while we still are in this world where there is cancer, to be able to have a patient, if they're newly diagnosed, regardless of cancer, that they get broad testing, right? That there's no barriers. It's not like, oh, well, if you only have this disease, you can only get these 3 genes. And if you have this disease, you can only get these 4 genes. And because we don't really understand the complexity of it very well. I mean, in the world of lung cancer, if someone starts off with an EGFR mutation, sometimes resistance happens in the form of an ALK mutation. Right? Or I had a patient this week who's got 2 distinct cancers with 2 different mutations. I only know they're different cancers because they have different mutations. So I'm going to have to, we're coming up with some combination treatments, right? So there's more complexity than we realize, and we don't know what we don't know because we're not looking.
Sure.
Right? And so I would love to be in a situation where any patient who gets a diagnosis gets a pretty broad testing of their tumor genetic changes.
Yeah.
Yeah.
Yeah, please.
Yeah.
I think this is a really unfair question, but I'm going to ask it anyway.
Okay.
So, you're talking about all the, these similarities across cancers and everything, and how the general oncologist in the small community doesn't always know all about them. But even in places where they do, are living here, I'm just going to talk about our case, which is my husband is still seeing a, quote, general oncologist. And, for the first couple of years when treatment was pretty straightforward, that seemed like a good idea. And it was fine and things were good. But I guess the question is, at what point, if any, does it really make sense to go to a specialist for lung cancer rather than, not just as a second opinion, but for general care?
So that's a great question. I think, there are more and more, because cancer treatment is becoming so complex, even in the private practice setting, people are becoming a bit more specialized at times because there's a realization that it's really not possible to know everything about every disease, right? And even for a person who's newly diagnosed with metastatic lung cancer, the quickest test to get now is the PD-L1 testing, which is the immune marker, and that's a long, complex story. But that's going to come back first before you get any of the genetic tests of the tumor back. And so what we worry about is that comes back, and if you just have to know one thing about lung cancer, like, okay, high PD-L1, I can just give immune therapy without realizing, oh, well, you can have high PD-L1 and have one of those mutations in the tumor, and if you do, immune therapy is not the right choice. It's going to be the targeted treatment, so teaching people to kind of wait. And if the oncologist then says, okay, well, I know for lung cancer I have to get PD-L1 and I have to get these gene changes of the tumor, and if I get that, I know what to do first, right? And that's still pretty standard. But then what about resistance, right? Because that can get very, very complex. And then what do you do when you do after someone's had 3 or 4 lines of treatment and they're still in good shape and they still want to keep getting treatment, but there's nothing that's standard? Like, how do you figure out what's the right approach and what? It's really clinical trial access too at that point. And so it's hard to really answer your question directly, and you started off with that. I mean, obviously, I have some patients where I know that we're early on in the treatment course, and the treatment I'm going to give is exactly the same treatment they would get in many other places. And for those folks, many of them will just come and see me at one of those transition periods where the scan's no longer looking so good, and we need to decide, is this a case where radiation alone and continuing this standard treatment is the right thing, or is this a situation where we need to completely change treatment, or is this a situation where, hey, this is a trial that looks really great and this is the time to switch? So they'll come and see me just every few months. Or every 6 months, or hopefully every 1 or 2 years if things are going well. And then once it's into the situation of, okay, we've been through multiple different treatments, what's the standard treatment? For someone who sees pretty much only lung cancer patients, and a lot of them every week, I'm going to have different experience than someone who is seeing lots and lots of cancer patients, but only seeing a few lung cancer patients and maybe only 1 or 2 with EGFR or ALK or whatever the rare mutation is, right? So it's going to be a little bit individual, and I think it's something to kind of talk to the oncologist in that setting and say, all right, at this point in my care, have you had other patients in this situation, and do you feel like you've got that full breadth of knowledge on this, or does it make sense? And obviously, the relationship between patient and oncologist is usually pretty close, because it is that's one of my realest things about my job is that I get to know so many wonderful people in a way I wouldn't otherwise. And so usually those conversations can go okay. I think that most of us are able to give an honest assessment of that. If you have someone who reacts badly about that, that's not a good sign either. So, right? So I think it's tough. I think when someone's been through 3rd, 4th line, then you at least want to be asking, is there a study? Is there something that would be potentially better? Is there something that's a little bit sort of off the regular path that would make more sense? But it doesn't have to be that you're switching your care entirely. You could just go in and kind of get that opinion at that point.
And just a shout out to our patient services team. Certainly it's not a replacement for conversations with your physician and care team, but it is a great supplement. And Michelle and others who can get on the phone with you, point you in the right direction. We have a lung match program that actually actively searches for clinical trials with you based on the information that you provide. And we do have programs that can help people get testing at different points in that journey. So the last piece is we have been able to get people second opinions that maybe they couldn't travel, and we've been blessed to have a great network of physicians like Heather that if we send out an email saying, here's someone we're working with and here's their case, they'll in many cases respond and say, here's some ideas. Here's maybe how we would treat this patient. So just know that we have resources to help with it as well. I think you have a question?
Yes, question. So once a patient is diagnosed as EGFR, does this mutation continue forever, or do they change over time?
So that's a great question. In general, if there's what we call a driver mutation, we believe that that's sort of the root cause of the cancer. We can't answer as to why a cell in that person got the mutation to begin with, but we know that the mutation in that cell was that led to the cancer growing up. And so that kind of root mutation is going to be in all of the cancer cells. But then over time, the cancer cells growing in different places can develop other changes. And so when someone's been living with cancer for a long time and has been through multiple different treatments, there'll be that primary EGFR mutation, but there will be, and maybe in some places there'll be the T790M mutation, and other places there won't be, or there can be other mutations that get added on. So it becomes more complex over time, which actually then can be helpful for immune-based treatments, because then it becomes less like the rest of the body and more unique to the cancer. So there's some more things that the immune system might be able to recognize. But the primary mutation stays there. Other things can pop up though, right? So we talked about you can have EGFR and then you can have ALK added on top of it. It's rare that you'll lose EGFR completely, but they're rare cases of that. So it's another one of those, the more we know, the more we understand that we don't understand, right? So it just gets more and more complex.
So Heather, thinking about this topic really quickly, because I do want to make sure we move on, and we're already moving through, because again, it's a meaty topic. Are we finding with other cancers who also maybe have a targeted mutation, the same type of thing happening with resistance mechanisms and so on as they go down that treatment pathway? Very similar, I'm assuming?
Yeah, so I can't speak to all of them quite as well, because that's out of my little world, right? But yes, I think that the interactions between all of these different pathways is quite complex, and so it makes sense that if your tumor is dependent on one pathway and you block it, that other things are going to come up around it. So those are what we call the bypass pathways, or there'll be changes within the primary protein that change the way it interacts with the drug that's trying to block it, right? So those are kind of the two big themes that come up.
Yeah, I mean, you kind of picture it as an evolutionary struggle. That it's kind of like antibiotic resistance, to put in a metaphor that maybe you can relate to, is that the cancer is trying to win, and it's a struggle between the cancer and your body. And so there's that competition going on and the cancer trying to survive when you keep throwing different drugs at it. So how can it escape or, keep going? An example of that, I used to teach a college class to freshman students, and I used the Emperor of All Maladies as the text. And going back to your Gleevec CML story, so CML patients have this kind of unifying mutation, and Gleevec was the targeted drug developed, for those patients. And there's an anecdote in the book talking about a patient who went on Gleevec, and most patients go on it and do well because you don't see as much of that kind of resistance evolving. But there was a patient who did acquire resistance, and the researchers were able to go in and kind of quickly develop the next drug for that patient. He went on it, and went back into remission. So it does occur. I mean, there is that pressure, on those mutations.
Before we switch gears, Michelle, anything online? No? Wow, quiet group. All right, fair enough. So again, in our time that's left, I'd like to hone in on two topics and maybe start just because, again, I want to make sure we at least touch on it. You mentioned early on immunotherapy is now starting to show promise. Maybe a little bit about that and what you're seeing, similar to TKI's, a bit short of an answer, but just kind of what you're seeing as the next evolution of immunotherapy and how that may play into things. And then the kind of last area I'd like to make sure we talk about, because I think there's this crossover, is what are things you're seeing in other tumor types or in other cancers that you're excited about maybe moving into the lung cancer space, because I think that's important for people to know as well. And in mind, one of those things in my mind is CAR T, so maybe that could be one. But maybe let's start with IO, and then we can turn that around and ask, what do you see going the other way?
Sure. Okay. So we talked a little bit about, so when we talk about immune therapy, that's a really broad term. Obviously, it's anything that's getting the immune system to better attack the cancer, recognize it as foreign. When we use it casually, usually we're now talking about these checkpoint inhibitors or the PD-1, PD-L1 drugs. It's all the same thing. So it's drugs that block that interaction between the PD-L1 and PD-1, which is one of the ways that cancers hide as normal tissue. And so there's multiple different drugs there. I'm not going to go through all the names. And those are, we now know, very helpful. If there's a high PD-L1 level, one of the drugs can be used by itself. Other levels, you can give it in combination with chemo and get a lot of effect for metastatic disease and some long-term survivors now, which is fabulous. More recently, we know that if you can improve cure in stage 3 disease, where patients are often getting chemotherapy, radiation, we add this checkpoint drug to that, the durvalumab, and it seems like we're actually changing cure rates. And now there's a bunch of trials being done with those drugs for patients with earlier stages of disease, either before or after surgery. That's all still very much research, though. And so that's the kind of where we are with immune therapy. But that's really just the checkpoint immune therapies. So where the research is now is that PD-1, PD-L1 is only one of many, many, many different regulators of the immune system. So there are a lot of different drugs that either turn on pro parts of the immune system or turn down other parts of the immune system, and trying to, again, find the balance between not causing too many autoimmune problems, but getting a better attack on the cancer. And so that's where there's a ton of research going on. We heard about one of those trials today, and so there are many others that are ongoing. And those approaches are not being looked at just in lung cancer. So those approaches are being looked at across multiple different tumor types. And I think it's the origin of sort of where the cancer started. So we're all here talking about lung cancer. Cancer started in the lungs. The pathways that are abnormal, some of them, like EGFR mutations, are really only seen in lung cancer. But then some of the other mutations are seen across tumors. So why does an ALK mutation sometimes become lung cancer versus lymphoma? Is it just where the mutation happened, what cell it was in, or what? Those are things we don't fully understand. But we know that there's similarities across cancers, and then there are differences. With the immune response, we're sort of looking at more similarities, right? It's about the body being able to recognize something that's not like the rest of it. And so that's where there's a lot of research and a lot of excitement now. And so immune therapy is going to involve those other treatments too. And then when we talk about CAR Ts and other things, that's going even a step further. So the drugs, mostly IV drugs, are going in and throughout the whole body, changing the way that the immune system's interacting. But CAR Ts and other things like it are actually taking T cells, so the actual immune cells, and they're modified. And then sometimes they're given back into the body almost like a bone marrow transplant, and sometimes they're able to match sort of the specifics of the immune system with specifics of what makes the cancer look different than the rest of the body and give those back, and those are engineered T cells. Yeah. And so those have been most effective so far in the liquid tumors. By that I mean lymphomas, leukemias, which makes some sense because you're able to, cancer is very accessible. You just draw blood and there's the cancer. And so you can manipulate those cells in different ways and then reinfuse them. With the solid tumor, it's a lot more complex because you have to be able to get it to the cancer, and it's just other issues that are more than I'm going to go into right here. But the excitement that's being seen with the CAR Ts and liquid tumors, obviously there's a lot of hope that that's going to be able to translate it into the solid tumors. For all the reasons mentioned, we're still a little ways off from that, but a lot of excitement with it. And with these other ways of better getting the immune system to work. As excited as we are about targeted treatment, it's sort of putting our brains against the cancer in its fight to evolve. If we can get the immune system to work better, then we can step back and let the immune system do what it's been evolved to do, which is to recognize things that are foreign and attack.
That's great. Yeah. Anything else that you would point to that's kind of on the horizon, maybe coming over into the lung cancer space? If not, we can always move on.
Yeah, no, I mean, I really think it's about a better understanding the immune system. The more we can, there's still a lot we don't understand about the immune system and how it works. But as we understand more, we're evolving better treatments that are going to find that balance between getting the cancer recognized for what it is, which is a foreign thing, and getting it taken care of.
Yeah. I mean, for me, the parallels from your story and my story are interesting because, even though you went into medicine, I went into basic research. And I was reading this book. I brought it up here it's called The Transformed Cell, and it's by one of the pioneers in immunotherapy. And I read it as I was transitioning from college to grad school. And, the early days, back in the 80s, early 90s, of when, very crude immunotherapy approaches were approved for renal cell carcinoma and then melanoma. And, that's really opened up all the advances that have occurred with checkpoint inhibitors. And, the Nobel Prize was issued, just last year for immunotherapy to Jim Allison. But I think, what drives me in this effort was the realization, Amy's not going to be the one who cures cancer. I need to empower and equip people like you who will. And so I have to source, the science. I have to find the people who are doing the cutting edge approaches and, get them the resources and the tools they need and advocate for funding and do all those things to create that ecosystem that drives everything forward. With the targeted therapies, a lot of times these patients will come to us and they say, what about immunotherapy for us? Is that an option that's on the table when I run out of drugs, or when there aren't any more options on the table? And so, I've talked to researchers who are, our knowledge is increasing, but there's still so much we don't know. So are there, for example, other immune cells that might be there in the tumor that we can identify new and different biomarkers that would maybe open up immunotherapy options or additional immunotherapy options beyond PD-1, PD-L1, TMB? So that's a big piece of, some exciting stuff that's going on. You talked about, you were diagnosed when you were 30. So we've done a lot of work looking at the genomics of young lung cancer and what is this phenotypically distinct form of lung cancer that's occurring in patients who are younger than 40. We know that it is distinct in that patients at that young age, have an 80% or greater occurrence of targetable mutations. Why is that? So we're delving into understanding the reasons why these young, otherwise healthy people are coming down with lung cancer. And just today I had a conversation with a researcher who, they're looking at, a surgeon coupled with a researcher who works in animal models, a comparison of young mice and young humans versus, aged humans and mice, and understanding that there are different kind of tumor microenvironments. There are some things that are distinct in those populations. So there's still so much we don't know, but the pace of advancement is just breathtaking, and there's so much hope. I think that's always, you go to ASCO, and over the last couple of years, that is very real, those words, those letters on the wall, and that's gratifying, I think, for all of us who have been in this field for, years and have not had any options that were good to offer patients. So, yeah, I mean, I think there's a lot of stuff that's on the horizon.
Yeah. Well, we talked on a lot of things that we had on our list to try and cover, and just the fact that the targeted therapies really have had a huge impact. Obviously, when we went around the room earlier today, so many of you had an actionable mutation, whether it be EGFR or ALK, and we know there's many, many more. And truthfully, we are seeing that same knowledge, as we talked about early on, transferring down into the other cancer types. With immunotherapy, we know it is. We can see the changes, and we're seeing it now approved across cancer types. The reason I keep kind of hitting on that point is one of the questions we get a lot in Washington, D.C. when we go and advocate. One of the things we get a lot from funders when we ask them to invest in lung cancer research is, why should we invest in lung cancer? Stigma, I think, plays a role in their question. But for a long time, we didn't have a great answer other than a lot of people were getting it, which you think would be enough, right? If you're looking at improving rates from people passing away from cancer, you'd go to the one that's taking, unfortunately, the most lives, but that wasn't the case. We now have a compelling story, in my mind, that's different than many other cancers in the fact that lung cancer research has driven change for so many other people. My brother is one who's going to benefit from our folks at BMS, Opdivo and Yervoy will be the combo that he'll more than likely go on if, unfortunately, it ever progresses. But that came, again, from lung cancer and melanoma. And so one of the things that I've heard a lot recently from people who are looking at research is the reason they started in lung cancer was, frankly, the patient population. And there were enough patients there to actually do a study to now get statistical significance, and we're seeing that benefit then translating down. Do you think that's true, that just because of the sheer numbers, unfortunately, of patients, we're able to maybe do a bit more in lung cancer, not only the advancements that we've had, but the fact that there is a large number of mutations, that there's enough patient population? And the reason I'm asking is I want to be able to go to those people in D.C. and say, the advancement speaks for itself. Imagine if you'd invested in this 10 years ago or 15 years ago, where we'd be today. So don't keep waiting, right? Come and invest in these things. But what are the other reasons we should tell people that investing in lung cancer research is a good thing, and how is it being, how's it driving, and how is it changing, and why?
Well, I think that the main issue is it impacts so many people. And again, we don't understand why it happens to many of the people who get the disease, but it is still very, very prevalent. And as you mentioned, I mean, it's still, the second most common cancer for both men and for women. It happens, regardless of age, regardless of many, many different factors, and so that's a huge problem. I think that our ability to break in lung cancer, it's not just one disease, really. I mean, it is and it isn't. And perhaps because it is so prevalent, we were able to break down into the smaller groups and still be able to impact people in different ways. Is that going to be the same story for every cancer? It might not be. I mean, we are no longer thinking about all breast cancer the same. We've got different markers that we look at to change how we treat. Colon cancer, it's also the same. I mean, the BRAF or the KRAS story, BRAF and melanoma, KRAS and colon cancer. So we do know that there are molecular differences that make the cancers different, even if they started from the same cell of origin. And with lung cancer, that sort of led the way there. I don't think it's just about the sheer numbers, though. I think that there are differences in the biology. And I think that the immune differences, right? It's getting back to sort of this idea of like the immune system is really where we need to go if we're going to make the biggest impact for the most patients. But there's still a lot that we don't understand. And I think that to be able to say this is where we were and this is where we are, and it's just a huge difference, but look how much more we have to go, I think that would be the more compelling story.
Okay. Yeah. No, I like that. Thank you. Yeah, I mean, that's been a challenge, truthfully. Yeah, please.
Yeah, tonight's subject was what other cancers lung cancer works with, and I was wondering about breast cancer, which is getting so much more money than lung cancer. What's the overlap between lung cancer and breast cancer in the research and clinical treatment and so on?
So that's a great question. It's interesting. So breast cancer has actually been one of the hardest with the immune treatments. They haven't been as effective there. And with breast cancer, there's a lot more hormonal-based approaches to therapy. So I think that the bigger issue about the finances, and that's been something I think those of us in the world of lung cancer have been screaming about for a long time, is sort of the inequities of the number of lives lost versus the dollars. Not that we wouldn't want any less money going to breast cancer research, but just that we also want more coming to lung cancer research because of that disparity in lives lost. And it is partly the stigma, right? Or a lot of it has been. It's one thing to walk around pink and talk about breast cancer, and no one says, "Oh, how did you get that?" Right? It just is, and so it's something people can support in a different way, and it becomes empowering of women is one of the things that people talk about with it also, even though that's not really the story, but it became the story. And with lung cancer, because of the smoking connection, and again, I know many of the people in the room with lung cancer never smoked, and that's not the whole story, but it was the story that many people have in their mind. And so when someone talked about, well, I have lung cancer, it gets back to that, well, you did that to yourself, even though that's not the case, right? That's not the story, but that was the story that people had, and the feeling that if someone was advocating for lung cancer research, then they were maybe making smoking okay, or they were supporting the tobacco industry, or, and that was the misperception that happened. And some of it goes back in time to a lot of the early tobacco advertising also linked it in with being healthy. And I mean, there's some of the folks at Stanford have, done some, look back at the advertising that was done and still is being done, right? That sort of leads people to feel like, oh, well, smoking is a bad thing, and therefore lung cancer is a bad thing, and therefore we don't want to fund it because it's just all of that stigma issue. It's all ridiculous, but it's there. And until we've completely worked away from that, it does become an issue. People still kind of look at lung cancer differently. So that's been one of the challenges with funding. So, and again, I know that at least for my patient population and most of the people here, smoking had nothing to do with the lung cancer, but we don't know what did. And so that makes it hard to say, well, it's not that, right? So it's just a difficult thing.
But it sounds like from a science standpoint, because that was kind of the initial thrust of the question, it sounds like due to the differences that you identified, there doesn't seem to be as much crossover maybe as with some other tumor types.
Right. So the specific targetable mutations, not so much. Reaction to immune therapy, not so much. A lot of other great drugs. I mean, there are one of the crossovers that we do have is with HER2. So HER2 is related to EGFR. EGFR is also called HER1, so that's you can think about it that way. And so some of what's known about some of the breast cancer drugs is helpful in lung cancer treatment when there are mutations within HER2. And so that's one area where there has been a direct crossover, where because there were drugs developed for HER2 and breast cancer, when HER2 was identified as a driver mutation in lung cancer, those drugs were then used. And what we're learning about treating HER2 lung cancer will hopefully be able to be crossed back over towards breast cancer, but that's a kind of a small percentage of it. And so it's not quite as much crossover.
Yeah.
But as you mentioned, there's still 30-40% of that pie that we don't know yet.
Yeah,
so there's still unknowns, and there might be some of that overlap. But I think that is the general mindset now that cancer is really a disease of acquired mutations, and understanding what those mutations are and looking at the overlap will open up insights, and that there is the opportunity to apply these therapies across tumor type. And but how can we embrace the lessons learned from the advocates in breast cancer and do some of those same things in lung cancer? That would be.
And I think one of the key issues there is the screening. So I think where breast cancer has really done a phenomenal job with their advocacy is making people aware of the importance of screening, and therefore so much of breast cancer is found early enough that it's highly curable. And that's something that in lung cancer we really need to learn from that, and to really adopt better screening.
So we probably have time for another question in the room, and then otherwise we'll have to do some wrap up. So any last questions? Anyone? All right. So there could certainly be a part 2 to this conversation, because we didn't really get to talk about the screening. We didn't get to dig into some of the other challenges, but we want to thank everybody for being here. Thank you for the conversation. Certainly a bunch of us will be sticking around to answer questions later. So I would get in trouble if I didn't do all the housekeeping, and I have a timer here counting down. So first off, the next living room will be here in San Carlos, and that'll be July 16th. And the American Society of Clinical Surgical Oncology meeting, or ASCO, was mentioned a couple of times. The topic for that meeting will actually be kind of the best of ASCO. So what did our scientific team and Dr. Jacob Sands see this year from the data that came out that they're most excited about? So it'll be a very, very good topic. On June 22nd, we have our Go-To 5K in Portland, Oregon, so still a chance to sign up for that and join us. Also on June 22nd, Don Stranthanan will be, as we mentioned earlier, having his Celebrating Survivorship event from 10 a.m. to 10 p.m. to celebrate his 10 years. So we're very excited, and Don's been raising money for our foundation, but well outside of what he's done from raising money, Don has truly been one of the most powerful patient advocate voices in sharing his story and what he's gone through, and also being there for questions and to help other people. So if you've never met him, he's truly an inspiration. So thank you, Don. I hope you're watching. Sorry you couldn't be here tonight. And sorry I can't join you on the 22nd. My family already had commitments, but you know I'll be there in spirit, good sir. A huge thank you, obviously. Well, let me back up one other event. We already mentioned the Advocacy Summit coming up in July. Just a reminder, there's still an opportunity to register for that. We'd love to have you on Capitol Hill talking to your elected officials and telling them why they should be investing more money into lung cancer.
July 21st through 23rd.
July 21st through 23rd. Thank you. Some thank yous. Thank you, as always, to the patients, the caregivers, certainly our panel. Heather, you're always so welcome here, and you're always great when you join us, so thank you.
Thank you.
And thank you for everything you're doing for patients and across the country and across the globe, really. Really amazing, the work you're doing, so thank you so much. I want to say thank you to Evangeline. Kim Shapoyster, who normally is here and helps get us set up for food and everything else. Evangeline mentioned that, you know, we're kind of second family. The truth of the matter is she's family to us as well, and she came here early to get the salad and get the food ready and get it put out there, so a huge thank you for doing that. Thank you to the Office Bar and Grill for supplying the food. They always do an amazing job for us. For those of you not in the room, we have not only the food, but we do have our wine that we get, and that comes from Bonnie and Tony. So I always want to say thank you to them for as well. Penn TV. I know Danielle mentions that every week they set up their own little production studio in the back room back there for us. Unbelievable job. Today, yeah, I'll hit the done here. So that doesn't beep the whole time I'm in here. All right. At like noon, they started showing up with their equipment, and I was like, who are these people coming to the back door? I'm like, oh, that's right, they do get here that early. So a huge thank you to Penn TV. And if you can't fall asleep at night, they do broadcast this in the wee hours to help people get a second helping of it, so to speak. And then finally, a huge thank you. We get challenged every once in a while, and I'm just going to take a little bit to go on a soapbox here. We get challenged every once in a while about accepting support from the pharmaceutical world. My answer to the folks who ask me about that is always the same. When the federal government steps in and funds us at a level that we're able to do all of this work for the patients plus the other things that need to be done, I'll consider maybe not taking that money. But until then, if pharmaceutical companies are come in and show the care that they do for the patients, to give us the money to put on programs like this, to continue to develop the drugs that they're doing, we're going to take that money because they're not asking for anything from us other than to make sure people know about the drugs that are available, that testing is important, that molecular tumor testing should happen, and that patients are educated. So, government, if you're hearing this, fund us at the level of breast cancer, and I'll be happy to have a conversation about whether or not we want to accept dollars from others. But until then, thank you to people like AbbVie, Amgen, AstraZeneca, Bayer, Boehringer Ingelheim, Bristol Myers Squibb. Thank you for being here. I know we got Genentech in the room. Celgene, Dignity Health, Genentech, Lilly, Medtronic, Merck, Novartis, Takeda, and Tesaro. They are absolutely partners for us in this fight. When we go to ASCO, they sit down with us and they ask us questions every single year. How can we help you better? How can we support you? What can we do? And I just want to give a big thank you to them for being there because we couldn't do this without them and we couldn't support patients without them. So thank you so much for that. And thank you, all of you. And with that, we'll close it out and be available for questions. Thank you.
Thanks. Thank you.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. Yeah, we can both be heroes. like soldiers in their nice clothes, like soldiers in their nice clothes, together. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest, like sailors in a tempest, together. And it could be just you and me. We'll be family. Just wait and see. So I'll be brave if you're brave. I'll be brave, but only if